So I wanted to just really move on now to the treatment options, because there are a number of treatment options for our patients who don't have targetable mutations. And when we think about first-line treatment, a lot of us have familiarity with some of the regimens, the Keynote regimens, the Keynote 407, and what was the other? So Keynote 189 and Keynote 407. So these are chemo-IO combinations. And now we also have data for the CTLA-4 PD-1 combinations with Checkmate 227, Checkmate 9LA, and Poseidon. So I wanted to talk about the different regimens that we have. How do you choose between these regimens? Are there particular patients where you're going to be more likely to offer that addition of a CTLA-4 inhibitor? And so I think, this is an area of, active investigation and exploration, as we're really trying to understand what is the best treatment for our patients. And of course, the comparator arms for a lot of these trials was just chemo alone, right? So they weren't compared head to head.
I would say in first line, PD-L1 is still, I think, our best predictive biomarker. So certainly if patients have PD-L1 high without any of the high-risk mutations like STK11 and KEAP1, I generally favor PD-1, PD-L1 monotherapy, and we have approval of 3 different agents that are very well tolerated with excellent quality of life and really good results based on large phase 3 trials. For patients that are PD-L1 high, but for some reason have high-risk features, maybe they're highly symptomatic, high disease burden, maybe there's additional co-mutations that I'm worried about, those patients, I probably would navigate more towards chemoimmunotherapy. And again, if it's the STK11 and KEAP1, navigating towards using a CTLA-4 containing regimen. For those patients, I would tend to use Checkmate 9LA. But could also use Poseidon, and we can talk about that as well. For the PD-L1 low or negative, certainly chemoimmunotherapy. And then for the robust PD-L1 negative population, I generally think about using a CTLA-4 inhibitor combination as well. Tend to use Checkmate 9LA as my preferred regimen there. And then the squamous population, we were talking about how that's a high-risk population. Again, navigating towards the CTLA-4 inhibitor, but also I think depending on, comorbidities or performance status, may use Keynote 407 in the squamous cell population as well. There was an interesting negative signal, and I would say with Poseidon, with the regimens used in Poseidon, which might have compromised the results of that benefit of Poseidon in the squamous cell subsets in that trial. So in the Poseidon trial, they actually had a lot of patients using gemcitabine-based regimens with the combo. And we didn't see that benefit of, the regimen like we saw in Checkmate 9LA and in the Checkmate 227.
Was that attributable to the gemcitabine? Right. We don't know.
Right.
Yeah. Martin, Kent, how do you think about this?
Well, it's a difficult question, a many unanswered question. First one is, does the patient need chemotherapy or doesn't the patient not need chemotherapy? That's still sort of a clinical judgment call. I think it's mainly a short-lived response that chemotherapy adds. I think we've moved away from thinking of chemotherapy as an immunosensitizer that contributes to long-term durability. I think that's more predetermined in the biomarker setup and driven by the respective immunotherapies used. There's also a question about histology and the regimens that we use for treatment. For me, PD-L1 is the first marker. I agree with you. Giving a PD-1 or PD-L1 alone in a PD-L1 negative setting is falling more and more out of favor. We have 3 prospective trials now that show a robust benefit in the PD-L1 negatives with the addition of CTLA-4s with 2 agents, both with tremelimumab and ipilimumab. And I think that data is pretty practice influencing for me. I do use them for sure also in patients where I have low expectations of immunotherapy response in the PD-L1 lows, or if there's a resistance mutation. I know this is still a controversial field, but STK11 and KEAP1 have really been seen over and over and over again to be associated with a lack of PD-1 response. So if I see these mutations in an eligible patient, I think of CTLA-4s in addition, even when the PD-L1 biomarker is higher. And then as I get closer to closer to 100%, 80%, 90%, 100%. I think oftentimes of immunotherapy just as a monotherapy if there's no clinical indication. So it's really not one size fits all. The chemotherapy contribution mainly for clinical assessments, and then the question of whether or not a patient needs combination immunotherapy mainly on PD-L1 status in my practice. But there are other considerations as well. I do think that tumor mutational burden is still in the mix for consideration. Not really prospectively validated, but I consider this an additional bonus. Think of smoking status as an independent factor of decision. So I would never give, even with PD-L1 high level, a never smoker, an immunotherapy alone regimen. I think the responses there have been underwhelming. I think we need the addition of chemotherapy. So it's a very, very much patient by patient and clinical scenario by clinical scenario kind of decision, and certainly not one size fits all.
What regimen would you use for that never smoker?
Well, it depends on the setup. If a patient is never smoker and doesn't have an identifiable actionable mutation, I think typically a carboplatin, pemetrexed based regimen, plus or minus immunotherapy. I mean, I think pembrolizumab or cemiplimab here would be reasonable options. I don't know that I've seen any data that CTLA-4 can overcome the immunotherapy resistance that it comes with never smoking status. So one of the PD-1 based chemo combinations.
No, I agree, Martin, Ticiana. I think for a lion's share of our patients, 189 is probably a standard of care. The standard of care is fine, but I do think there's subsets that I consider the addition of CTLA-4. I like CTLA-4 inhibition. I come from actually the skin cancer world, so I'm familiar with CTLA-4, IP3, even IP10, so don't really have a lot of issues with giving IP1 or giving Tremi for that matter in our squamous cell patients and our brain met patients, and probably for STK11 keep as well, keep Tremi, but probably even IPI has a role. It probably still works. It's just a little bit of CTLA-4. I don't think everybody needs chemo. When I have a patient that comes in, particularly if they're PD-L1 high, I ask myself, but even PD-L1 sort of low, is this a patient that's going to die in 6 weeks without chemo? And if the last patient I put on 227 was they had a 3 centimeter very symptomatic brain met, they got resected, but a fairly asymptomatic apical mass and maybe some very small mediastinal nodes. That patient probably after their cranium and SRS doesn't probably need chemo. That person could probably get away with just IO. And so I think it is patient dependent. But I'm a believer. I think there's just and I think we don't have to probably dose CTLA-4 forever, right? I mean, median number of doses in 9LA was 6 and 227 was 5. And again, importing from the different disease model, but we've seen in the skin cancer world that probably just Nadina today, right? If you had a near CR, the curve was flat. And so you're probably okay with just 2 or 3 doses. So we're probably okay. We're going to probably do what we're going to do with CTLA-4 after just 4, 5, 6 doses. The preclinical folks may tell us that we're expanding a population of memory T cells, or we're not after several doses. And so I don't think we have to dose CTLA-4 indefinitely, but I do think it has a role in some of our diseases.
But can we go back though, because in those trials, the more significant reason for discontinuation was either progression or treatment-related adverse events. So I don't know that data guides me to stop CTLA-4 inhibitors because there was a reason that therapy was discontinued, right? So while I agree with you,
with just a few doses.
And we have Poseidon, where the Tremi was just given for a total of 5 doses, right? And so even though I think the checkmate studies, so 227 and 9LA, continued the Ipi-Nivo as a maintenance therapy, Poseidon was very different in that sense. And so that was my next question to you. I mean, how do you decide between Poseidon and 9LA? Are you using, are you differentiating these regimens based upon the duration of the CTLA-4? And again, they haven't been compared head to head. We do have some patients who absolutely don't want chemotherapy. I like the idea of 9LA of limited chemotherapy. Poseidon, of course, it was 4 cycles of chemotherapy. So how do you decide between them?
Well, one thing I just, I had reviewed thinking about how can we identify who are the people that are the long-term survivors in non-small cell lung cancer throughout all of these trials? Is there any clinical factor, any genomic factor? And the answer is no. But when you go back to the melanoma data where they have people that are surviving 10 years, and you look at all the regimens that led to like the people that were 10 years out, they were all nivo-ipi. They were more likely to be nivo-ipi, just talking about it in a simplistic way. So, and in the melanoma trials, again, the duration of how long to use immune checkpoint inhibition, including CTLA-4, I think is a very important question. But those patients were on long-term therapy too, right? So while I think that we still need to define the duration of how long to use immunotherapy in general, including CTLA-4 inhibitor, it's not clear to me what the optimal duration is. And again, and maybe I'm extrapolating from the melanoma data and how I view Checkmate 227 and 9LA and Poseidon, I tend to favor continuing the maintenance and sort of
The
dropping,
CTLA-4 is maintenance, yeah?
right, and dropping the chemotherapy through Checkmate 9LA. Whether, Tremi for 5 is optimal, I guess we'll never know because those regimens you can't really compare. But I will say that I tend to favor sort of using CTLA-4 longer term, like the Checkmate 227 and 9LA, hoping that that's really what's driving the survival in those patients that are going to be long-term survivors. But it would be nice to have, additional data to really guide us in a definitive way.
It would, and on the same token, I think I have a low threshold to stop the CTLA-4 inhibitor if I have a patient who's experiencing an immune-related adverse events, which we know those rates are going to be higher in patients who are getting dual inhibition.
Yeah, and I think, the data is reassuring for that, right?
Yeah.
We saw now with long-term survival we have 5-year survival for a lot of these regimens, including 5-year survival for Checkmate 9LA, 5-year data in terms of toxicities. And we saw throughout all of the different landmark analysis that over time, if patients had to discontinue due to treatment-related adverse events, they still didn't have a compromise in their outcomes.
Right.
So I think it's reassuring that if there is a struggle in terms of toxicity or side effects, that you can stop the CTLA-4 inhibitor. And I think that's
those
reassuring.
patients may actually be doing better, right? There's data to support that.